Going to record the last presentation. Um I'm going to talk about our results in endoscopic cholesteatoma surgery, and I'm going to talk about one singularity of my practice that actually is, maybe it's adequate to you, maybe it's not. I think that every practice is different, and you have to adapt what you do to solve your problems. That it will be probably different or maybe the same as me. In theory, how to treat cholesteatomas, you can have a CT scan, and in the CT scan you can draw a line just posteriorly to the lateral semicircular canal. And actually, if the horizontal line, the cholesteatoma, just stay anterior to the line, it's probably possible that you can manage the pathology just with a transcanal endoscopic approach. But if the pathology kind of extends posteriorly to that line, it will be hard for you to remove it from transcanally, and you will actually have to access a canal wall-up mastoidectomy. That's theory, and as I said before, the practice context is important. In my case, I have a long waiting list for CT scans and DWI MRIs, so they're not very available at the moment I want them, so I have to wait for results. And also, we have a long waiting list for surgical interventions. Usually, for cholesteatomas, we try to prioritize them, but still we have a surgical waiting list of 4 to 3 months, because actually we have a lot of cholesteatomas. So that problem, I needed to solve the cholesteatoma problem, because I cannot rely on the CT scan to plan my surgery. Why? Because if I have to have my CT scan in February and then I'm going to operate the patient in July, there's a 5 months of difference that actually, maybe if I want planning a transcanal endoscopic approach, it wasn't doable, because the extension of the cholesteatoma was already down to the mastoid. So I cannot rely on the CT scan. So what was my problem? My problem actually was that that I had a lot of recurrence rates within the group of just transcanal approach, and not that much, and it was good. Results were good with the combined approach. For that reason, probably, that we don't address the mastoid, and then we thought that the mastoid was clean, but it wasn't, so we had recurrences. And also obliteration. In this case, I try to systematically obliterate the mastoids, because there's a lot of importance here. Actually, the most important in this case, as we do canal wall-up to mastoidectomies, is to reconstruct the external auditory canal and the attic, what is called the scutumplasty. Because if you don't reconstruct correctly your attic defect, you will have another hernia with a noturia, chronic noturia, recurrent noturia as well. Even though if you don't have a cholesteatoma recurrence, this ear will go wrong, and you will be a surgical failure, and you will have to go and operate on it again. So it will be actually a surgical failure. Also, it's also known that mastoid obliterations produce recurrence reductions and accelerated mastoid healing in these cases. And with canal wall-up mastoidectomies is not a problem. You will have also a normal EAC, so you can prescribe the patients at standard hearing aids. So how we do it, how we obliterate, what we do is to raise this fascioperiosteal flap. It's a posterior auricular artery, fascioperiosteal flap, and the artery runs through the mastoid tip. So we pedicle the flap at the mastoid tip. It's a long flap, but actually you can do an L-shaped flap or a T-shaped flap, or whatever you like. But the thing is that that the important thing is to raise the fascia, the temporalis fascia, and do it as a continuum with the mastoid periosteum to pedicle in the mastoid tip. So it's an inferior-based flap that you can use. You're just very versatile. We got the idea from a paper from 1999 that's called the Singapore swing flap, and actually we use it a lot as an analog to the nasoseptal flap. It's like our nasoseptal flap for the ear. So we use it to reconstruct defects, to to reconstruct, to repair CSF leaks and meningoencephalocele. It works very, very good as is with tissue filled with fibroblasts. It kind of gets a very good adherence to the bone. It works very, very good in that manner. So as we're showing, we just design our anterior and posterior cuts and the periosteum, and now we're going to desperiosticide from a superior to the inferior way. See how we're going to remove and pedicle the flap at the mastoid tip, so we won't interfere us through the mastoidectomy as well. Here's the flap. You can present it, and it's a long flap. It's versatile, and we're going to use it to put it inside our mastoidectomy cavity, the corridor, the mastoid corridor. And here is an example. This is a cholesteatoma. It's actually a mesotympanic, epitympanic, and protympanic cholesteatoma. We're going to remove it in the usual manner. We try to remove what we can from the external anterior canal. Then we're going to elevate our tympanomeatal flap, as we usually do with the electrocautery. You have to do good incisions. You're going to work in the attic area, so you have to do a very anterior and inferior cuts. So you pedicle the flap anterior inferiorly, because we're going to work in all the rest of the circumference of the AIC and the tympanic frame. We elevate the flap and we expose the lateral process of the malleus to continue our dissection. Dissections on cholesteatoma are not easy. You can find a lot of retractions, a lot of different states, a lot of inflammatory mucosa, and as well as cholesteatoma scales everywhere. So sometimes you can find a disease in facial nerve. So you have to dissect it quite carefully. So we're now removing the jugular chain. For cholesteatoma surgery, what I do regularly is to remove the incus and remove the head of the malleus. Why? Because it will get you a very good access to the anterior epitympanum. You will have a whole view of the epitympanic space, and actually you won't regret it, because you will be able to see where is the disease. These cases are apparently in the retrotympanic space. There are no disease in the sinus tympani and the sinus subtympanicum, but there is disease in the frontotympanic space. There's also the third hidden space where you may find a lot of recurrence rates. You see the adicotomy here. Actually, we don't think there's a pathology in the antrum, but still, as I have a lot of surprises before, what I do now is to do this approach every time, even though maybe not be necessary. I believe the results are very good if we do it that way. So now we're trying to remove the last part of the cholesteatoma in the protympanic space, just anterior to the cochleariform process. That is here. Here's the facial nerve, and here's the cog. Now that now that the disease is removed from the middle ear, we proceed to a canal wall-up mastoidectomy. Actually, we're going to use a regular mastoidectomy here. The well-aerated mastoid kind of show us that probably there will be no cholesteatoma in here. So that's why we're going to use it just to put our flap inside and reconstruct and do our scutumplasty in this manner. So as you see here, there's no mystery about the canal wall-up mastoidectomy. We're going to enter the antrum, and once we have a very wide exposed antrum, is what we call an open corridor, the corridor of the mastoid corridor that we call for entering to work with the endoscope. So we always recommend to check this cavity and enter with the endoscope to check if there is any leukonostatoma left in there, just to be sure. Recurrence rates with assisted endoscopes in the cholesteatoma surgery are also get better in residual rate results. And what we use here is this flap to reconstruct the attic, to do the scutum-plasty in this manner, and now we're going to reconstruct the circular chain and the tympanic membrane. This is how you get here. Actually, this is soft tissue reconstruction, and actually, if you have a cholesteatoma pearl, probably the cholesteatoma will encounter this soft tissue and won't pass through the mastoid again, so it will get through directly from the AAC, and you will see an early recurrence if you have it. Same thing, but another reconstruction, but still, this is the attic, was reconstructed in here. And results, I find that my singularity was not, or I was not wrong on in the first intuitions, and I find out that I had in my series the first 60 patients that we standardized the technique. I had a 73%, mostly 3/4 of my patient had antrum involvement. So I was not, my intuition was not wrong to do this approach. And my residual cholesteatoma rate after 1 year of control of the disease was 8.3%. So it was 5 out of 60 patients. And the rest just are like normal results. 60% chance, 61% chance of getting a post-operative membrane gap less than 20 dB is acceptable for cholesteatoma surgery, and that's it. Thank you very much for watching, and I hope it's useful for your practice. Thanks.